As we come to a new financial year, everyone's got their view on what they should be doing when it comes to the general practice contract and the NHS and how we can improve it. Well, the Times have brought out their 10-point plan. And in this episode, we're going to review it, evaluate it, and maybe restructure it as well as we continue to tech enhance your primary care and learning. Hello, EGP learners. Welcome to this episode where myself and Andy are evaluating the Times' 10-point health plan for the NHS and stuff. How are we doing there, Andy?
Yeah, I'm doing pretty well, Gandhi. It's going to be fun taking this apart, I think. Another week, another plan to save the NHS, and this time it's the Times newspapers go at sorting out the problems. Yeah, looking forward to it, Gandhi.
Definitely. And it's rather interesting because this did come out with a bit of a fanfare. There was a bit of a publicity stuff that came out, particularly from the Times, obviously a big media organization and stuff. And it's a little bit different, I have to admit, that they have gone for some slightly different stuff compared to normal, I think, at least. Don't you?
Yeah, it's an interesting list, and I guess maybe we'll talk a little bit later about what they're trying to achieve by going for this list and maybe this sort of selection that they've gone for. I guess just so people know what we're going to be doing, there's a 10-point plan that the Times have delivered. I'm not sure that they've put it in any particular order, but we're going to take those 10 points and put them in reverse order, starting with what we think is probably the least effective or less exciting of those points, leading up to what we think is the most exciting single point that they have suggested. So it's going to be quite interesting. But I suppose before we start, it may be worth just talking about what the Times have done, because it's not just a story, there's a bit of process behind it. So shall we bring up, so this is one of the stories. So they've kind of had a series of stories that have been generated by this work that they've been doing. They have set up a commission to look at ways of solving the problems facing the NHS. So they've there's some quite interesting names in this panel of commissioners that they've assembled to contribute to this work. Let's zoom in a little bit. So we recognise a few people here. So Claire Gerada, former chair and president of the RCGP. I'm noticing Lord Darzi of the Darzi Centres and so forth. So he's the former health minister. There is Sally Warren, who's director of policy at King's Fund, for example, former boss of Marks and Spencers, and author of a government review into the NHS. So it's people from the worlds of business, health. I think there's a little bit of kind of academia. I think a little bit of sport as well, and nutrition.
Dame Grey Thompson's Baroness Grey Thompson's there. I can see that name. I can see some other ones. So Dame Jane Dacre from the RCN. I can even see Dr. Mark Porter from the BBC podcast and stuff.
Oh, there is.
So, yeah. So some interesting names there, definitely.
So interesting group. And what they say they've done is they've been into hospitals, GP surgeries, care homes, met with members of the public, taken evidence, looked at things that are done in other healthcare systems in different parts of the world, looked at things that are done in different parts of the UK NHS, and that's all contributed to what is quite a long report. And we could do a longer deep dive podcast on the whole report, to be honest, because it is quite in depth. But they have generated 10 headline points.
Yeah, and we're going to have a look at those right now, aren't we, Andy?
We are. So shall we switch and just sort of do them in reverse order then? So because we've kind of played with the order a little bit. So shall we take them in turn? So I'll take number 10. I guess what we felt was probably the least exciting to us as GPs, working in primary care. So they said they will incentivize NHS staff to take part in research and put the case for research to their patients, giving 20% of hospital consultants and other senior clinicians 20% protected time for research. And I think research is important, but as you'll see, a lot of the other points they make are quite resource intensive as well. And it does leave me wondering, actually, if we're taking 20% away from the resources that we have to deliver the other things, how are we going to deliver the rest of the plan? So that's interesting. What did you think of this one, Gandhi?
I mean, it's no misnomer. I'm not the biggest fan of research. It's never been the part that inspires me, shall we say. But you're right. It's really important. Research helps determine what treatments we should be looking at in terms of things we need to consider. And obviously, it can be really beneficial. But you're right. That 20% figure just speaks of unrealism to me. in a workforce that is clearly challenged. I mean, if you take that's a fifth of the workload that, particularly senior clinicians. It focuses a little bit more on hospitals as well. Actually, research is far better done, generally speaking, in general practice for majority of public health based research and that kind of stuff. So I don't know. That's the reason I think we put it lower down. I appreciate other people probably put it much higher up on their agenda, but I guess me and Andy are looking at this from the perspective of GPs in primary care, looking at the 10-point plan by the Times.
Yeah, I mean, and also, Gandhi, I mean, spoiler alert, all of these are quite expensive, and none of them talk to how they're going to pay for anything. So just spoiler alert for people.
Big caveat there, yeah.
It's all quite aspirational stuff. Gandhi, do you want to lead us into the next one?
Yeah, so next one that we thought was a little bit lower, and I appreciate some people may, again, put this one higher up, but we felt this was the best place for it to put it. So there's a guarantee that all children and young people requiring mental health support can get access to treatment within 4 weeks and rapid follow-up appointments, published data on waiting times for mental health services. Now, I think it's a really good idea to put this in. I think access to mental health support and stuff is really challenging. But I think when we rank this against some of the other ones, for us, I think it just came down a little bit lower down the list because of the other stuff, to be honest. It's not because this is not a good endeavor. I think it really is. Yeah, it was just the other ones ranked a bit higher for us individually as GPs.
It's really, really important, but it was quite a narrow suggestion, whereas some of the others are a little bit more broad in terms of their scopes. I think that's the reason why it's here, but I think it would be an absolutely fantastic thing and possibly more affordable, although quite expensive than some of the other measures that they propose.
Well, that's interesting. It's probably the most realistic, achievable out of the ones in some ways, which to some people working in those areas, they're probably thinking, if that's the most achievable, what on earth are they talking about for the other ones? But we're going to get to those now, aren't we, in terms of number 8?
Absolutely. So number 8 is establish a national care system, giving everyone the right to appropriate support in a timely fashion, equal but different to the NHS. So really what they're talking about here is we've got the NHS, the National Health Service. Care is often is funded in a very different patchwork, piecemeal sort of way across the country, with people contributing, their own money, top-up fees, means testing, local authorities. It's all very, very complex, and they're suggesting creating a national care system. I think this is we hear about this quite a lot. It feels like it would be quite expensive, like a lot of things on this list to do. If you think about the functioning of the NHS, a lot of what slows down people's process into and through and out of hospitals is the availability of social care. It can be difficult to discharge people back to the community safely unless there's good quality care waiting for them, and that means that those people are still in a hospital bed. That means that people can't move up from A&E to hospital wards, and that's why people are waiting in ambulances and waiting for ambulances in the community. It all knocks on. So it's a good suggestion. There must be some really good ones waiting above it, Gandhi, if that one is only number 8.
So number 7 was create a digital health account for patients called a patient passport. Access through the NHS app to book appointments, order prescriptions, view their records, test results, referral letters, and contact clinicians. Now, this one's slightly interesting because actually that's pretty much what you can do through the NHS app already. I guess the reason why I thought it was slightly higher than some of the earlier ones that we mentioned about is actually making this mainstream, I think, needs to be a priority for the healthcare system, because actually having a single doorway into the healthcare system, which is what the NHS app has meant to be, and encouraging people to use that will mean that therefore we can streamline the way that people access care. And actually all those things are stuff that they said they could probably do. So this one's probably achievable and fairly quickly as well. So that was my view. What do you think, Andy?
Yeah, I think so. I think the kind of the word patient passport is potentially a little bit that's different from the NHS app in a way. And whilst we don't know the detail behind this, that speaks more to a portable record or a kind of interoperable record that can travel with people. And that's something that we're always banging on about. Actually, why does the emergency services have visibility of a different record to general practice, which give you a different record to hospital? Actually, if the data just traveled with the patient, that would be so much easier. So I think it's a good one, and potentially achievable, although we've been working towards that goal for a long time. So it always feels
very much so.
It's like the nuclear fusion of general practice. It is 5 years away.
But I think that's the other thing with it as well. This is one of the ones that actually, if they manage to do it, which logistically sounds possible. Actually, the savings you would have in terms of, potentially health outcomes for patients, but also cost savings you would have from delivering this, I think would be really valuable to both the healthcare system and the population as a whole. But hey ho. Number 6, Andy.
Tackle waiting lists by introducing a national program of weekend high intensity, and they've called that HIT, like HIT training, lists once a month in 50 hospitals to get through a week's worth of planned operations in a day and create 7-day surgical hubs. So that's their way of clearing surgical case backlogs, I guess. Which, it sounds really sensible. There's a big backlog, big waiting lists. Sounds sensible, potentially achievable. Apart from who's going to work
do
at
it?
weekends and who's going to pay for it, of course. But sounds really good.
Definitely agree. I think, anything to tackle the backlog would be appreciative. I think there's some structure in there in how to do it. I think they haven't considered obviously the workforce costs and the the cost of the estates and all that kind of stuff to deliver that. But actually, yeah, this would help so much of the other aspects of healthcare that we are currently struggling with, especially the backlog and things. That then raises what is the top 5, and we're about to go into those right now. So number 5 was establish a Healthy Lives Committee empowered by a legally binding commitment to increase healthy life expectancy by 5 years in a decade and reduce health inequalities to encourage a long-term approach with a cross-party agreement. Now, there's a couple of buzzwords in this one, which is why myself and Andy put this a little bit higher up. Absolutely, there was the health inequalities agenda on this particular one, and this is one of the main ones that focuses on health inequalities. The cross-party agenda, the fact that this would be signed up by multiple parties, so then it's less of a political football when it gets pushed around when it comes to election time, and actually the fact that they are mandating that this is a government responsibility to deliver, making it part of that agreement that they have to do this, actually puts a focus on promoting healthy living and well-being and stuff for patients, which feeds into one of the ones coming up in a little bit. But what do you think, Andy?
Yeah, I like the word legally binding, and we were debating what that actually meant, and we hoped that meant binding the government to meet these targets.
Yes.
I think that's the only way it can really be meaningful. And I was quite interested that this is perhaps one of the only measures that is quite. It gives a specific goal. Increase healthy life expectancy by 5 years in a decade, so we can actually see if that's working and if it's delivering. And actually, once you've set that main goal, people then need to work out how to deliver it, and it's probably about looking at a major disease strategy, which you've heard about before. And actually a lot of very specific actions can fall out of that big goal. So that's why I thought that was actually quite a good aim and a good point. Moving up, so number 4, introduce a no blame compensation for medical errors with settlements determined according to need to ensure families get quick support and encourage the NHS to learn from mistakes. So, this is quite high, really. Maybe that's us being defensive as clinicians and often fearing these sorts of actions. But I suppose the process, whilst it's can be quite difficult for organizations and practitioners to go through, it must be it's obviously even worse for families. Families can take a long time to get the financial support they need to carry on living their lives. So this sounds very sensible to me.
I agree. I think it's not just about protectionism, though. This is about patient care as well. So one of the things that repeatedly we hear about when there are these, slightly massive scandals that we hear about hospitals and all that kind of stuff is down to the fact that there's very little whistleblower protection around in terms of raising these issues. And actually, I would see that comes in part of it, that actually this would open the transparency and raise the problems as well that come up, so that hopefully then they can be fixed quicker and there's less of this need to hide stuff that we see from some organizations, unfortunately. And actually that would mean to less pain and pressure that patients experience as a result of it and things. So I guess that's why I wanted it higher up. I think absolutely supporting clinicians to feel that, that they're not going to be vexatiously targeted for doing some things, maybe not the way that people wanted, or wrong in that sense, because actually wrong is a perspective sometimes. But yeah, I think as ever, we need to learn from the mistakes, and hopefully that would help to deliver that and stuff and things. That's different to number 3, though, isn't it, Andy? So this was me talking. So this was an interesting one, tackling obesity. So, we know obesity is one of the biggest determinants of how ill health and stuff. But by expanding the sugar tax, taxing salt, implementing a pre-watershed ban on junk food advertising, and reducing cartoons on packaging to minimize children's exposure to unhealthy food, this is basically a public health campaign to make us all healthier. Now, I know there are going to be people out there that are saying it's going too far. It's
the nanny state.
Nanny state. That's the word I was looking for and things. But let's be honest, it works. It's one of the only things that works to tackle population-based obesity. So yeah, it makes a no-brainer for me on this one.
Yeah, I'm quite a fan of this approach, really. We have a sugar tax already. A lot of people did oppose it, so nanny state sort of arguments. I think now that it's come into place, that's all sort of gone quiet. And what's happened really is that rather than taking and paying the additional tax, soft drink manufacturers have reduced the sugar content of their drinks. We've all got healthier drinks. They're not paying the tax to a great degree. We've all got, they're still making money. They're still in business. We've all got healthier drinks, and maybe your Coca-Cola doesn't taste quite as good as it used to, but people should be healthier as a result. So taking that principle and expanding it to cover other areas, I think is really good. I think it is a little bit different to public health campaign in terms of this taxation approach is a little bit different, and I think it's interesting, and I think it would be interesting to expand that into other areas. The other part of this is legislating for advertising. It's actually almost a little bit old-fashioned, though, isn't it? A pre-watershed ban on junk food advertising. So I'm not sure how many children watch live TV. Gandhi, you've got kids in your household, but aren't they all watching sort of YouTube and so forth? So maybe we need to understand what pre-watershed, before 7 o'clock in the evening means in a digital world. But I'm assuming that they mean to translate that concept into the digital world. But yeah, really interesting. And one of the only suggestions that doesn't look fabulously expensive. So, so number 3.
There we go. Number 2, Andy, tell us about this one.
Yeah, so reform the GP contract. So I think we had to put this near the top, being GPs, in terms of this is going to excite us, if that's the right word, about contract reform the most. So reform the GP contract to focus on wider health outcomes rather than tick boxing, ensure patients get prompt appointments and restore continuity of care, encourage more super practices, and create community health centres. So I don't agree with all of this being mandated. I think what I like is a focus on wider health outcomes. But that's quite hard to do. Actually, QOF, for all its ills, focus on things that can be measured. It can be harder to measure wider health outcomes. So I think that would be difficult to actually implement. I like continuity of care being in there. Sometimes in a resource limited system that runs at odds with prompt appointments. You can't necessarily have your cake and eat it. And then I'm not quite sure about more super practices. And community health centres, never sound like a bad idea, do they? But I'm not quite. We'd have to delve deeper to see what they mean by that. What did you think about this, Gandhi? There's a lot in this one.
There is, and like you said, some really powerful points there in terms of continuity. There's, changing the way, the culture in general practice to move away from some box ticking particularly for resources and that kind of stuff. Actually more community health centers is probably what we need. Services delivered closer to the community. I'd expand that to be, moving secondary care into the community as well, which I think is always a positive agenda and part of the whole integrated care movement and things. But again, this is the one that talks about reforming general practice. So I guess for us as GPs, we're probably going to put this higher up on the list compared to some of other things. The question is how they do it, as ever. That's the devil in the detail. So we will probably find out some of the
controversial number 1, which could be considered, doctors putting something that's very much on the doctor's agenda. At number 1, it's just struck me looking at this again. But fire away. What did we say was number 1?
So number 1, there's a reason why, particularly I said I wanted this as number 1, but to read it out. So write off student loans for doctors, nurses and midwives who stay in the NHS to improve retention as well as recruitment. Debt should be cut by 30% for those who stay 3 years, 70% for those who stay 7 years, and 100% for those who stay 10 years. Now, as Andy mentioned, this is very much specific to, I guess, those working within the NHS. So less focused around the population and the public. But I guess the reason why I particularly would put this one quite high up, we are in the midst of a recruitment and retention crisis in general practice, as well as the healthcare service in its totality. So, what's one of the biggest issues? Loads of doctors, loads of nurses, loads of clinicians come out of training with huge debts. And actually, we want them to stay in this country. So, how can you do that? Well, loads of people keep saying that we need to force them a mandatory service, conscription style, army style and stuff and things. Actually, I like this one because it incentivizes you to stay, but doesn't necessarily penalize you for going in the same way that a mandatory conscription style one would do, or that you have to pay back the loans in its entirety, because actually you're choosing then to take a life elsewhere in preference of the potential debts that you've accrued. I think there's always the question about the amount of debt people accrue by training for these things. So actually, to me, this does make sense and stuff, and would help to tackle the recruitment and retention crisis that we face currently in the healthcare system. So would potentially have fairly quick effect as well, because we're talking individual money. What do you think, Andy?
Yeah, I mean, I can't oppose it. It sounds like a good plan. I think you're right. It's quite smart in terms of meeting a few objectives in terms of trying to retain people within the UK NHS system, not going abroad, not going into private practice. It's so what I thought about this was, it's so two things. Well, what does this mean if you sort of calculate it as part of people's pay package? In terms of in terms of because this is sort of a bit like a pay increase, really, if you're staying within the NHS, and most people do stay within the NHS for the first few years after graduation. So I just thought, actually, does this contribute to sort of a pay settlement, or we're talking about industrial action at the moment. This is the sort of thing that actually could be an outcome from industrial action. This could be something that the BMA could actually look at. So I thought, actually, this sounds quite practical, quite current. Was what I was thinking. And then part of me was also thinking, oh, is this a bit like indebted servitude? When you say, well, I'll go and live in America, but someone pays my ticket for me. This is in the early days of emigration to America, and then you have to kind of work off the cost of your ticket when you're there. And that was a sort of controversial sort of thing. Although I guess a lot of people did it. So it's almost like binding you to your employer, like like you're a medieval serf. I don't know. I'm probably going over the top. It just sort of sounded a bit interesting.
It does.
So yeah. Interesting. So, so those are that's us reordering it. I think we had to put in some order. They're all pretty good. And
so, shall we just quickly show them on the screen share as well, Andy? Because I know we've talked about these rather than show them. So, if you did want to have a look at it, like we said, this is from the Times newspaper. There's the 10 points. They're in a different order to what we've done, because we've reordered them in terms of, I guess, our priorities. But you can absolutely have a look at this.
And you can look at the whole report as well.
The whole report, yeah, absolutely. I guess there's the question of what's missing from this. So, I don't know. What did you think, Andy?
Well, first of all, I was thinking, what's the purpose of this, right? Because they're not saying how they're going to pay for it. So my first reaction was, this is all very well and good, but it doesn't really sound achievable in an environment where we can't pay for any of this, potentially. But then I thought, actually, that's probably not the purpose of this. First of all, there might be more detail in the report, but I think they would have brought that forward into their summaries if there was, about how to pay for it. But I think the purpose is to grab people's attention, to shift the framing, shift the debate, onto new ground and into new areas, and turn heads. So I think that's what they're trying to do. So I kind of just wanted to make that point, I guess, rather than tell us, being one of those reports that's fully costed and tells us how it's going to be afforded. I think it's about grabbing attention. So that was my thoughts. But did you have any other reactions to it, Gandhi, on first reading it?
I think, like you say, it was just a little bit more out the box than some of the standard kind of plans and stuff that we see. So in that sense, it was really nice and refreshing to read, to be honest. I just wish they put something in there about how it would be paid for.
Yeah, I guess so, but I'm not sure that's what they were going for. I think they were trying to just turn our heads really. And actually, we've pulled some interesting ideas,
Definitely.
out of it, which is interesting. So what was missing, Andy? What would you find? Let's go through a few things that we would put in there if we could.
So, I mean, if I was, health minister and that kind of stuff, that probably one of the first things I would look at doing is actually scrapping prescription charges, because I think that prescription charges in England, in particular, are a false premises. At the very least, reviewing the payment system, because I think it's outdated, archaic, and frankly, not evidence based either. And actually, by tackling that, I think we would see an impact in health outcomes, particularly when we're in a recession. Now, obviously, the automatic question will come, well, how are you going to pay for it? Well, we probably spend a good chunk just trying to get people to pay for things anyway. And the cost savings you would get from people who don't take their medications because they can't afford them, taking them and therefore being healthier because they're actually taking your medications. The big one being inhalers. I still think it's a travesty that patients with asthma and COPD do not get their inhalers for free, compared to other health conditions, which those admissions cost the NHS so much more money. It's anyway, I've ranted about this numerous times, but that would be the first thing that I would say could be addressed and changed, and not currently in this plan or most other people's plans.
That's a good one, Gandhi.
Sorry, I ranted again, didn't I, Andy? Apologies.
I'm going to throw in a friend of the show, the much called for Office for NHS Responsibility, or an oversight body. So similar. So when the budget comes out, you have the quasi independent Office of Budget Responsibility that produces a verdict on government budgetary policy and seeks to explain to us what the impact of that policy is. And prior to the budget being published, the OBR is involved, so the government knows what the OBR will say about the budget, before it comes out, and that informs how the budget's done, and it tries to make sure that we have a responsible budget. When the OBR is not consulted, you have something like the Truss budget when they didn't consult the OBR, and it was a disaster. So I think actually health policy would benefit from an independent sort of oversight body that just keeps an eye and talks to the government and government ministers about what they're proposing, to make sure they fully understand, best evidence-based understanding of the impact of what they're suggesting. Health is complex. In some ways, it might be more complex than fiscal and monetary policy, but I think it would be a good thing to try and implement. So
definitely agree. Yeah, no, absolutely agree on that one. So the next two we kind of felt were quite controversial. Which one should we go for first, Andy? The really controversial one or the slightly less controversial
Well, it depends
one?
what we think is. So I'm going to say we'll go for the most controversial one last. And I think the least controversial of the last two is a debate around the affordability and scope of the NHS and how we pay for it. So that's quite a leap, right? So I wonder what the last one is. So what was missing from this was a discussion about how to pay for it. And we've talked a number of times on the show about how maybe there's a place for a discussion with the public, honestly, about what kind of a NHS and health service can we afford on, can we get with current funding? And if we want something different, how would we pay for it? What would that mean in terms of taxation or potentially even other funding models? I think that sort of debate is long overdue, but difficult to have within the political environment that we have. So that was that one. Anything to say about that before you drop the most controversial one?
Well, I think it's always going to be difficult to have. That's the problem. It's always in the too difficult to do pile. So therefore it never moves into let's try and deal with it pile. And that's the problem. We're dealing with the situation with the NHS in particular, that, it is not affordable, but there's no question about how we're going to tackle the funding, how we're going to tackle the process. There's now questions about combining health and social care budgets, but actually that doesn't solve the problem. It just enhances it because it just shares the pain almost. So I think, a valid discussion with the public about the priorities of healthcare, as well as explaining the pros and the cons, and that debate about how is this going to be funded in the future needs to happen, because we are in a situation where there isn't as many funds as people think. But at the same time, what does this mean for the future? Because healthcare will keep getting more expensive. That's the thing. It's never going to get cheaper, ever. So we need to figure out how it's going to be paid for and things. So the last one we had, So interesting, Andy thought this one was less controversial, more controversial. I think it's less controversial, but move sick note certification out of the NHS, that it's actually dealt with by a separate entity, an occupational healthcare service or, whatever. But in terms of welfare state assessments, to be done not by the healthcare, the NHS itself, not by general practice, where the lion's share of that happens, because actually, is that a positive or negative outcome? That's something for you guys to think about, to be honest, and let us know down in the comments. I think. What do you think, Andy?
Yeah, I think it is fairly controversial. I mean, I think there are other health systems around the world. People often tell me that in Holland, GPs don't do the sick notes, for example, that it's done by a different organization. That always sounds quite attractive to me. I think there's always something if it's, I would say maybe actually very short-term sick notes for short-term illness. Maybe the GP is the most logical person to do that. But I think beyond a certain period of time, which is probably not that long, then probably another organization, would be better to do that, because you start to run into difficulties with the doctor-patient relationship. If you're challenging the nature of some sick notes, that can be very difficult to do. And the GP then becomes not the best placed to do that, because there is a priority on maintaining a positive therapeutic relationship with the patient. So it becomes difficult, I think, beyond a certain period of time, which is not that long. So that's a good one. Yes.
So the question is, I think, for you watching and listening to this, what do you think? What are the priorities of the healthcare system? Absolutely let us know down below in the comments. If you're, watching this, if you're listening to this, send in some details. You can absolutely do that on our SpeakPipe. So the link's coming up here, www.speakpipe.com/EGP learning. And remember, the G and the P are capitals. The rest is all lowercase and things. And if you do want to let us know your thoughts on this, we would absolutely love to hear them, as well as what do you think should be the healthcare priorities for the healthcare system, and how do you think we should pay for it? That's the debate we need to have. Any thoughts on that, Andy?
No, I think we'll leave this with the viewers to answer those quite difficult questions.
Definitely. So let us know down below. Make sure you subscribe for the next episode, because we've got some really cool stuff coming in the near future. Make sure you check last week's episode, which was some mega updates on the end of general practice. And we will always be here to help tech enhance your primary care and learning. Catch you later.